On behalf of almost all of the Train Boston physical therapy staff, welcome to whoever is watching this. We wanted to come together and collaborate, kind of share all of our collective experiences and expertise and discuss some rehab topics and rehab processes that we commonly deal with a lot at Train Boston Physical Therapy. And I think when we were brainstorming ideas, the first one that popped into everyone's head was ACL tears, simply because the prevalence and incidence is so high in the athletic population. And really, we treat a ton at Train Boston Physical Therapy. So we thought that would be a perfect place to start. Before we get into the nitty gritty of actually what ACL rehab looks like, we thought it would be beneficial to just give like a brief overview of the ACL itself, its function, and then briefly touch upon some risk factors that could potentially help in the prevention of ACL tears. So I wanted to open it up to you guys with that.
Yeah, I'll start with that. I think in terms of ACL tears, it's important to have an idea of what's going on mechanically, factors that can lead to it. There's a lot out there in terms of prevention programs, people advertising, do these sort of things, and you can prevent an ACL rupture and reconstruction. So I'll talk a little bit about how realistic that is, the effect that has, and some of those things. So in general, ACL is a ligament within the knee, and its job is mostly to prevent shear forcing during dynamic tasks. So if we look here, you guys see that all right?
Yep.
At an internal view of the knee, you've got your thigh bone, femur comes down here, shin is here, and in between that, ACL runs from the back of your femur to the front of your shin, and it prevents that shin from moving too far forward or having too much rotation in it. So what can happen is if there is some sort of quick force to the knee, usually in a direction that bends it inwards, you can suffer injury to that ligament. So risk factors for this, what we need to consider is that most of these injuries, over 70% of them are non-contact. So these are people who are trying to change direction in sport. And for whatever reason, they're not able to meet the forces of that. So some of the risk factors that we will be more concerned with and athletes will be more concerned with is how do we modify these forces? How do we change what we're doing so we don't end up with a lot of shear force in the ligament? And within the knee, what's doing the action of a movement is going to be shared between muscle and soft tissue and non-contractile tissue. So, arbitrarily, this isn't how it works, but say muscle does 50% of the work of a movement and ligaments take the other 50% of the stress. If your muscle's now doing 30% and it's doing less, that ligament's going to take more strain. So the more you can make the muscles do around an area, the more protected those soft tissue ligaments are going to be. So in terms of risk mitigation, working on muscle strength and that neuromotor coordination is huge, specifically in that area, things that will prevent that sort of interior or medial knee collapse. And I'll share the screen again. But this is kind of your classic look of a non-contact injury here in the ACL, where the knee's coming in, the torso's coming out, and you're just getting that forward translation of the knee and a lot of that shear stress there. So in terms of prevention programs, a lot of the research is done in like these 20-30 minute pre-exercise programs, and they're actually pretty effective. I was a little surprised because a lot of these times I see these things that look just like a little bit more like marketing than anything else, because it is this very high incidence event. 70,000 reconstructions are happening a year. It's one of the most common orthopedic surgeries, the reconstruction is in the US. So, how much can we actually affect this? But throughout different studies with, thousands of subjects, their decreasing rate of injury by like 50 to 75% with some of these programs. And they're not that complex at programs. It's working on plyometrics. It's working on strengthening of, hip musculature. And in terms of the leg, strengthening the hamstrings, that hamstring attaches to the shin in such a point where it's going to help prevent that anterior force that can contribute to an ACL tear. So these programs are pretty darn effective at mitigating the risk. Prevention's kind of like a fishy word, because who knows how much we're going to prevent. There's so many things that go into injuries. It's so complex and things are so interdependent that you can't say you're going to prevent something, but you're mitigating that risk. We're not going to change these anatomical factors. You're not going to change the size of your tibia, but you can change how your body reacts to different forces. You can change what happens to your legs when you're landing, when you're jumping. Just a couple other things that jumped out to me. About 20 to 25% of people are going to re-tear, higher in a younger population. And in terms of the kind of prevention mindset, this is like a life cycle. It never ends. Like, you're in this sort of injury prevention or ACL prevention status, and then if you rupture, you're right back there, probably at a higher risk. So these things matter even more after reconstruction. So it's never like, some ACL prevention program and then you're fine, or if something happens and you do get injured, then it's not only post-op, then it's prevention again, because you're at a higher risk of re-tearing. Females are going to be higher than men. Some hormonal things, some people are talking about biomechanical things with hip angles, but females are like 5 to 6 times higher than men, especially at a younger level. That tapers down a little bit once you get into collegiate athletics, a little higher in high school athletics. Sports that are higher jumping forces, soccer, basketball, volleyball, those are kind of like the higher incidence sports. Football, for ACL ruptures.
Yeah, the only thing I would add is, I think at the end of the day, a solid strength and conditioning program is just going to be just as effective as a true prevention program. So it doesn't matter whether you do an ACL prevention program or just get into some solid strength and conditioning. Both of those will give you the skills or the prerequisite strength that you're going to need in order to avoid injury. Yeah.
I think, getting with someone who knows what they're doing and can, there's so many of these Instagram posts of, if you do Nordic hamstrings, you're going to reduce your like incidence or chance of ACL tears by 40%. It's like, well, that's something very static. You can't just like do a hamstring exercise and be good. You got to get with a coach that knows what jumping and cutting and turning looks like, because that's when it's going to happen. It's not going to happen when you're on both knees, like going down with a band. Right. I hope.
Yeah, and there's a big misconception in our world of the PT world that doing kind of isolation, open chain exercises like a clamshell or something is going to be enough to prevent that moment force from happening. And we have to more so put athletes in these positions where they're more likely to tear. So something like a single leg squat would mimic that a lot more effectively. And in my opinion, these ACL prevention programs don't even come close to a solid strength and conditioning program because of that reason. Because in strength and conditioning, we're going to work on things like a squat pattern and a hinge pattern and plyometrics and things like that are much more high threshold activities versus these low threshold isolation. Let's get your glute stronger. Well, that's not really going to mimic the forces you're going to encounter when you're cutting and things like that.
I think another big thing too is like on the other side of what Sean kind of was avoiding going into, but just to briefly go over like sleep and stuff like that, which a lot of athletes can manage a little bit better to reduce their risk, and making sure you're recovered and working on those aspects of it, which I'm sure we'll go more into on like a separate occasion, but obviously worth mentioning.
There's no exercises that are going to strengthen your ligaments, but nutrition might. Like having a good diet, having a good sleep hygiene, that's going to improve all your soft tissue, all that stuff. One other thing that I saw, Tyler, like you were saying, like the success of these prevention programs went up if there were, like this threefold. They broke it into plyometrics, neuromuscular training, and strength training. So like being able to hit all three aspects and not just saying, oop, I did my external rotation exercises, now my knee's not going to go into valgus. And then something that also that I thought was really interesting, which is really hard with high school athletes and adults even sometimes, but compliance. If participants weren't participating in the program for the 3 days a week and they dropped, the success of the ACL injury prevention dropped by 50%. So the likelihood of tearing goes up if you don't comply with this sort of thing. So actually having routine and doing this consistently is a big part of the equation.
Did that talk at all about age of the participants of starting the prevention programs? I think, sometimes when we get our hands on people or they come in with, maybe they've already had some knee issues or some repetitive stress from whatever sport it is, or, whatever their mechanism was. But I would think there'd be some data out there that kind of suggests, starting, preventative programs or more strength programs to really teach an athlete how to decelerate, rotate correctly, cut, pivot. You'd have a much better rate if you started someone at a younger age.
Yeah, absolutely. They had like 6 points of success for prevention programs, and the first one was the younger the better.
So it seems like big takeaway from that. Yeah, there are risk factors. No, we cannot completely prevent ACL tears, but we can certainly push people in the direction of a comprehensive strength and conditioning program. We're lucky enough at Train Boston to have all of that in-house. So it just makes the transition from training to rehab and back the other way just so seamless and easy. So I would just seek out, strength and conditioning professionals, excuse me, who really have experience in adequately preparing athletes and clients for the physical and physiological demands of whatever sport or task that they need to do. Because I think that's kind of the biggest thing from a prevention standpoint. But let's move on from there, because I think we kind of just crushed that. So a patient comes into your office, they did sustain a tear, imaging confirms that. They have a surgery scheduled a couple weeks from now. What are some things from a rehab and treatment perspective that you guys really want to hit on early on in the pre-surgery timeline? What are some specific goals that you guys have in mind there?
I think the pre-op stuff, is, you talk to every surgeon out there, some of the original initial goals they really want people to get in there, right? Help to control pain and swelling, regain that terminal extension, if they can even get a little bit past into that, really get that mechanics into extension, and then, kind of restore some quad ability to help get them to maintain, the extension right there. Some docs, want a certain degree of flexion, going in, which probably has more to do with how much swelling's in the knee than, what the capability of the joint is.
I would also say, you probably would want it depending on what else they did. So, someone who maybe sustained an MCL tear as well, you would probably push that surgery date out and wait for that to heal before you would necessarily go in the knee. So a lot of the patients I get, we're looking more at 5-6 weeks till surgery, which gives us a lot more time to work on exactly what Dave said. And then really regaining a lot of strength, because the stronger they go into surgery, the better they're going to come out.
Yeah, and that pre-op timeline is really useful for us to work on things such as end range quad strength, or getting a hamstring turned back on, or glute strengthening, single leg strengthening, whatever it is that we wouldn't necessarily be able to do right out of surgery, especially if they had something else like a meniscal tear that had to get repaired or something like that. And getting someone stronger preoperatively is a really good opportunity to just teach some of these concepts without a ton of post-op pain. Because when people come out of these surgeries, they're in a ton of pain, and it's hard to work on something like getting your hamstring turned back on when you're just trying to control pain and swelling at that point. So overall, I would say what our main goal is just to get somebody as normal as possible going into the surgery. I like to tell people that you want to feel like you don't need the surgery when you're going into it.
If you do have that time with them, just getting them exposed to some things, whether it's just the atmosphere of a physical therapy clinic they're going to, getting to know, some of the concepts that you're trying to build going into surgery. And then that I think gives you the opportunity to talk to people really about post-operative, rehab, and what's it going to really be like for the first, couple of weeks, extending into the 6 month, 8 month, 12 month return to sport phases. I don't know if people frequently get, really kind of a full kind of disclosure of what it's kind of realistically going to be like. I think they kind of get a little bit of an overview, or they get everything with with rosy glasses, that's going to be really, really optimistic. And that's not always the case. So I think, when we do get these people, preoperatively to help get them to the best possible phase to surgery, it also gives us an opportunity to really stress some patient education and really help them to understand what's going on with that reconstruction or the repair, whatever they're going to do, whichever procedure. And then really, where does that go, from day one of surgery throughout that continuum?
Yeah, I think you guys summed that up perfectly. I think just setting expectations and then kind of like restoring homeostasis locally within the knee is just so crucial to a smooth rehab leading up to surgery. And just, letting the patient know what to expect, because it is such a long rehab process. Giving them some ideas of what to look forward to, I think, can be so beneficial, really. So in regards to the actual surgery itself, obviously this is a little out of our scope of practice, as we're physically not doing the surgery, but patients will get different graft types depending on a number of factors. Can we just briefly hit on the most common ones that we see and in regards to the specific population and why some people might get a certain graft in comparison to others?
So I would say a lot of what I see is patellar tendon graft and an allograft, which is a cadaver. So they obviously do mostly the allograft when you're older, so over 40. So I see a lot of those. And basically what I've found from the research from school and stuff like that is that the allograft is a lot less painful because you're not taking graft from someone's knee. So those people actually tend to have a lot less pain going through rehab. The patellar tendon, obviously you're going through the front of the knee and you're taking that middle third of your patellar tendon and using that as a graft. So there's a little bit more pain involved. You definitely need a lot more compliance with like home scar mobilization and stuff like that, because that thing gets really tight. The other graft that there is the hamstring graft. I don't really see a lot of those, and I actually really haven't had any of them in the past 2 years. So I don't think I don't know if any of you guys have had hamstring, but obviously you treat it a little differently.
I don't think you see as many of the hamstring, grafts as you used to, or at least we don't in our population. But I don't know. I've always found people that get that, they kind of get prone to some other pain just because of the extra harvesting that has to go on with that. I always feel like the back of the leg kind of gets, pretty much, dinged up and bruised up. And then for some people, it seems like there's a little bit of a lag time of just, getting those hamstrings to really kind of reactivate to a level that we'd really like them to get from, stability world.
Yeah, normally with a hamstring graft, they say that mostly it's indicated for, teenage female athletes who, in my opinion, is a population who needs their hamstrings the most out of everyone.
Yeah.
And what I found is I've seen a couple, and on one of them, she went to study abroad. So I didn't see her from probably post-op week 4 on. She came back and I could literally feel her ACL at end range because she had no hamstring control when she came back.
Oh, jeez.
So, in this population of female teenage athletes, why are we taking a muscle that's super important for their stability and then telling them, hey, you need this, but good luck getting it back? So I think that's why we see a lot more patellar grafts, which is, in my opinion, the best one to get. It is a lot more painful starting out, but it's a lot more sustainable in long-term stability, in my opinion.
Yeah, I think the hamstrings also have a little bit of a higher retear rate with that. And then Tyler, what you were just talking about with that patient coming back that didn't really have any hamstring control, I think there's usually like a little bit more of a longer term strength deficit of knee flexion of those hamstrings relative to the quad. So sometimes that presents a barrier of just getting that balance kind of restored in the post-operative part.
The hamstring's like a 3 bundle, so they take the muscle and they make it into like a bundle. So it's actually a lot of them that re-tear, they like loosen. and that's like what causes some of that. Whereas like the patellar graft is bone, tendon, bone. You just take it right out of the knee and then put it in. So you have less of that kind of like people say like, oh, this knee feels like loose kind of. And that's usually with like a hamstring graft, you can notice that because it is bundled like that. The other thing I would say is that I think with hamstring, but I know for sure for patellar graft, your weight bearing as tolerated when you get out. Whereas the allograft, you're partial weight bearing for like 6 weeks, which obviously is because of harvesting the graft from a cadaver. You have to kind of let that heal. And so that's like the big difference, obviously, between those three.
Now, if you're watching this and you've had a hamstring graft, don't fret. There's still plenty you can do, but it's just going to be a little bit more focused. Patella, for them, there's higher risk of patellar tendonitis afterwards and anterior knee discomfort. Hamstring, it's just going to be higher risk on the back end. So you're going to have more. Well, everyone should have a significant focus on hamstrings, but hamstring graft, that's something that you really need to hammer home, because every surgeon's got a reason for what they do. They're comfortable with it. They have a high success rate with it. So if that is something that's been selected for you, then hamstrings are going to be a big deal in the post-op recovery process.
Yeah, I would say just try and do as much research as you can and talk to as many different people as you can to get their opinions, because everyone's going to have their own opinion. Obviously, my experience with hamstring grafts made me have this bias towards, not necessarily recommending them for most people. I can't really think of a population I would personally recommend for them, but every surgeon has their reasons, and they probably have a lot more experience in volume of these repairs. And we just are speaking anecdotally about what we see in the clinic.
Another thing to consider is whether they're having, if there was meniscus damage and if there is going to be a meniscus repair, or if there is going to be a meniscectomy. If you have a meniscectomy, you're back to walking faster than if you have a meniscus repair. If you have a repair done, you're most likely locked in a brace for 6 weeks with either non-weight bearing or partial weight bearing status.
So for the sake of just this discussion, when we're talking post-surgical timeline and rehab considerations, let's just say, just to standardize it, it was just a complete ACL tear. They did a reconstruction, and there was no meniscus repair. So for the early, we'll say about 0 to 6 weeks, that early stage rehab, what are some things that you guys think are super important to focus on early on, and what are some goals that you'd like your patients to meet before progressing them to that mid rehab phase?
Obviously, the first things you're working on are range of motion and stuff like that. Depending on, actually no, all grafts, you're pretty much trying to get that terminal extension is the most important thing. And I don't know if any of you guys have seen the like Edelman documentary thing on whatever, but they're like talk about the extension of it for probably 40 minutes of it, but it's so important for them, but also for the surgeons. Like that's what they're looking for when they go back to their post-op visit. They're looking that they got that, at least to a 0 for the 2 weeks, and then hopefully terminal like hyperextension after that. Whereas like the bends, like, as soon as someone's starting to walk more normally, that's going to come. Obviously you don't want someone at like 30 degrees, but as long as you're getting it moving, that's not as bad. Depending on if it's allograft or autograft, your exercises are going to vary, because if they're partial weight bearing, obviously you can't do a lot of what you would want to do for 6 weeks. So I sometimes struggle with finding like new things for them to do, because I'm like, oh, we can't really do anything weight bearing yet. And then like the huge thing for me is you guys can elaborate a little bit more on this, but like really getting someone's hamstrings to fire just as importantly as their quad, because that quad inhibition happens just due to the swelling from the surgery. So as soon as you can get the quad and hamstring getting like firing again, I use a lot of the complex and like muscular stimulation to try and get that working again and get some of the swelling out. So those are the main goals I kind of focus on, but feel free to elaborate, anyone.
I think the biggest things is protect the graft, reduce swelling. You want to try to minimize pain for the patient. restoring patella mobility. So that's your kneecap and how much it moves laterally and up and down. And then just educating the patient on how important it is to protect the graft and actually take time off and not push their brand new knee.
A lot of people are almost a little overprotective. Like they're like, oh, it really hurts when I bend it. And I'm like, well, yeah, you kind of have to go through some of that. Obviously there's some people that are like ready to like get on a bike and you're like, whoa, like calm down, like not yet. But for the most part, I find people are like scared to push through that. And I have to be like, you're not gonna pop anything. You're not gonna re-tear anything. You need to get that motion back. Like you have to push through some of the pain right now.
You know, I think every once in a while you get that random person who's, you know, like week 5 or 6 that is, you know, their swelling's down. They really have no pain, you know, like they feel great. And then they want to go out and do something a little bit too soon, like go for a jog or something that's just way, way too early and it's going to put the surgery at risk. So I kind of like, you know, in that time frame, if you do get that person who has really nice range, you know, their muscles coming back, they're able to contract hamstrings and quads well. It's also just kind of a little bit of a constant reminder of their timelines, and that even though if they're feeling really, really good and they have all these great, you know, markers of improvement, it doesn't give them the full clearance to go out and get back to sport. You know, a crazy early time. I had one guy try to go for like a 3-mile run at like 7 weeks, and somehow he made it through. He had a little anterior knee pain, but it was kind of like, man, we've talked about, you know, not overstressing this, and that there is a little bit of a time frame associated here to allow the correct healing from, you know, the you know, cellular physiologic level, but also just from your coordination levels to not put that at further risk.
So once they hit that end of, you know, that beginning stage, we'll probably say from 6 weeks to say 6 months, obviously keeping in mind that every rehab is, you know, completely on an individualized basis. There's a ton of factors to consider, but just for the sake of this, we'll call mid-stage rehab 6 weeks to 6 months. What are some things that you guys work hard to progress your patients through during that time? What does that overall kind of trajectory look like for you guys?
Take it, Cam.
So I think one of the biggest things for me, you guys crushed it in terms of that like early phase rehab, is, you know, reduce pain, reduce swelling, normalize gait, normalize range of motion as best you can. Once you kind of hit that 6-7 week mark, you can start to slowly build some strength, assuming, you know, the joint itself is moving pretty well. So that's when we start to transition into more of like a program that looks kind of like bare bone strength and conditioning, really. So starting to build strength locally around the knee, around the hip, and then slowly starting to reintegrate really all their movement patterns through like a variety of stances. So from that point to like that 12 to 16 or even 20 week mark, I really want to prepare the patient to get ready for running. So strength is a big component of that. Obviously, we want them to be able to tolerate the forces that are going to go in and out of the joint when they take a step. But the other part of that is we need to like slowly reintroduce very low intensity, low threshold plyometrics. And that's just kind of your standard strength conditioning progression, starting really easy, something that they're going to be super comfortable with, and then gradually progressing them to the point where they're doing single leg plyometrics, because that's essentially what running is, jumping from one foot to the next. So I want them to do that really well before we have that conversation of, okay, we're going to give you the green light to run outside of here.
Yeah, I would say going along with what you said, I'm really, I guess, in the beginning phases of that, working on teaching them to, you know, get in and out of not doing cutting, but like doing like a lateral lunge or something, getting them into their hips, getting them out of the hips so they know what that feels like prior to like, you know, getting more into the plyo stuff of it. And then like a big part of it is just getting them stronger too. So like I use the leg press a lot just because I feel like people don't up their weight enough to really create that change unless you're like having them on the leg press, like, no, we're going up another plate, you know, type thing. Recently, I've been focusing a lot more on like eccentric strength. So like really focusing on tempos, getting slow down. So as they can control that coming down, they're able to get back up eventually when we get to that phase.
I think during that middle part of that rehab, I think for a lot of, especially athletes, it becomes more of a mental game than it does physical, because they're going kind of stir crazy. They just want to move. They want to get back to what they're doing, and it can be a very frustrating time period. I mean, the initial 6 weeks, you're almost still in a little bit of shock from the surgery, but after that, and you start to move around, now you're starting to get the itch to start doing stuff. So that's the time that I love to utilize doing anything in the pool that I can to get people moving with as minimal ground reaction force through the knee or as minimal impact as possible, whether it's waist deep, chest deep, or non-weight bearing in the water. Get someone that's used to moving a lot without compromising the graft or the repair of whatever they got. So anything from, I mean, not just swimming, but just doing some standard kind of kicking drills, then progressing to, 20% weight bearing plyometrics or some shallow water jogging or anything like that. I think has a huge benefit, obviously physically during rehab, but more mentally, it gets people feeling just better overall. And then it gets more optimistic about your rehab instead of getting frustrated, or if there's God forbid a setback or anything in the process. It just gets people going, and it adds just another element for movement. But yeah, aside from that, I think what Bianca touched on with eccentric control of that quad is going to be absolutely huge.
I would just add for anyone who is watching this that with sort of some of those grafts, if you have an autograft, usually you're at your weakest around 3 months. So it's just something to be mindful of if you are kind of one of those go-getters, just to be really careful as you get closer to that 3 months. Try and not overdo it, because that's actually when the graft itself is the weakest as it's healing. So you kind of want to get over that hump and like have the right mechanics, have the right control before you kind of get into some of that stuff.
I think the difficulty, kind of like what Kev was hitting upon at this stage as well, is for people who are used to being athletes, they almost have this like identity crisis. So anything we can do to make them feel super athletic again and really challenge them, I think is like invaluable through the rehab process, and really gets a ton of buy-in. You do, I think, have to have that conversation though when people start to feel really, really good towards the end of this stage, that 4, 5, 6 month mark where they're back to running. They haven't really hit any speed bumps recently. You almost have to pull the reins back a little bit, just because the graft still needs some time to heal, and they're going to feel really good before the graft is ready for them to get back to everything that they want to. So I think just having that constant dialogue, reminding them that it's a process, I think that's huge, because towards the end of this phase, people are going to start to feel almost 100%, and they're going to want to, put the pedal to the metal. So I think just pulling the reins back is huge. Transitioning from the end of this stage to then like that 6 month return to sport timeline, what do you guys traditionally like to do throughout that timeline? What are some things that you really want to hit on before we say, okay, I'm confident you can go back to sport safely and do really well?
So I think once you have that kind of the equal strength in both sides, then we can really look at absorbing force before producing force. So like Bianca was saying, using that eccentric strengthening is really useful. And then working on things like med ball, like catching and tossing, to me is really valuable at that stage when you're starting to get back into it, because you're not exposed to these, huge amounts of force, but you're teaching somebody how to absorb force, for example, through their hip versus through like a knee valgus stress or something like that. And just teaching somebody how to absorb force on 2 legs and 1 leg is going to be huge during this phase. And then once you get that down, you really have to think, okay, what makes sport different from what we do in the clinic? And when you're playing sports, you're exposed to all these outside influences on your system. So if you have to track a ball there, but you're running to the left, that's going to be a huge difference rather than, just running to the left and worrying about that. So exposing somebody to different sensory inputs as they do their change in direction activities is going to be huge during this phase. But there's a number of studies basically saying, especially in younger athletes, at that 9 month mark, they're really not ready to go back. Even though they seem like they are, they feel like they are. Some doctors are waiting till a year out, which I kind of agree with, because if you take somebody, for example, who's a sophomore in high school, and they're an elite level athlete at whatever sport they play, sometimes their parents think, oh, this is our only chance to get recruited for college. But then once they get to college, they re-tear, and then it's like, okay, that whole career is out the window. So in my opinion, being a little more conservative on the back end is more valuable than being conservative in the beginning. And I think what we're seeing is in these kind of accelerated protocols is that quicker progression in the beginning, but then not rushing an athlete back to sports. And then if you look at somebody like, like Julian Edelman, who came back early, I mean, we don't know what happened behind the scenes. Did he get, $15,000 stem cell injections? Probably, which isn't really viable for the average person. Do you want to pay $30,000 for extra treatment or just go back 3 months later?
I mean, I think you get in that conversation a lot. There was Edelman, and then Adrian Peterson, and was it Welker also? There were 3 or 4 guys over the last couple of years that came back so quickly. I mean, they're outliers for a lot of reasons. Aside from getting to their facility at 5, 6 o'clock in the morning and doing every type of rehab possible with every type of medical professional. Physically they're also just outliers too. So, I think that's good things to remind people, when they are kind of getting itchy to get back to that return to sport phase.
This is also a good time to set up a relationship with the coaches, because you're not just returning an athlete back to sport. Even at that 1 year mark, you want them to go non-contact play first, then be able to get a full practice, and then be able to then transition a full play. So everything is still a step process of return to full sport.
I think I see athletes that are able to complete athletic maneuvers better than they can complete simple like movement patterns too. So I would err on keeping them away from sport for, like what Tyler said, is more that closer to the 1 year mark than the 9 month, because you don't want to miss anything. I mean, you could have an NFL wide receiver go ahead and run a go route or a post or a cut, but might not be able to do a proper inline lunge. Because they're athletic, they're using their athleticism to mask some of the smaller stuff. So we check off all our boxes, and everyone's got their own return to sport protocols, but as long as you're not missing anything and then letting them jump the gun and letting their athleticism take over for innate motor control, then you're going to just have a better outcome. And as long as you tell the athletes, listen, you don't want to go through this again, so you want to get back in 9 months, why not wait? Let's do another 3 months and make sure we didn't miss anything. Because if you tore your ACL from a non-contact move anyway, then there's something going on that you were doing incorrectly that we have to make sure you're still not doing. And again, athletes are going to be able to mask that compensation with athleticism, even after ACL reconstruction. So pulling the reins on them, I think, is always going to be more beneficial for them. And you might have to have that conversation with them. Like, listen, let's put yourself in check, and let's do this thing right, so you're not going through it again.
I think it's important to frame early on that everything preceding this 9 or 6 month mark is what gets us to here. Like in my mind, return to sport is day 1. Like, you want to run, okay, what are the components of running? You better get full knee extension. Like learning how to stand and have weight in your heel and march up your other leg slowly, that's return to sport. That's running mechanics. So every single component should be framed as, hey, this is what this is going to look like. And I'll demonstrate, like you guys know I do a ton of marching stuff and skipping, but like I'll show someone like a slow march, and then I'll be like, all right, and then it's this, and then it's this, and I'll demonstrate, then it's going to be a skip, and then it'll be a run, then it'll be a run and change of direction. And also, when you get to that point, when you get to 9 months and you're trying to teach someone how to get in and out of a cut and maintain their torso without going over their leg, you can say, remember like that drill we did like a couple months ago where we were like just shifting into your hip? Do you remember how that felt? That's what we're recreating here. So like, that's how I like it in my mind. And I think it can be beneficial for patients to feel that, okay, this is what I'm doing now, but that's only because it's part of this thing that I want to get to. And when we get to that, all right, this is what I want to do. This is how we got here, just to be able to get to those points and draw everything together. So it's not as phased out in the patient's mind of, yeah, I'm doing this thing now, and then I'll get to what I want to do.
Yeah, and I would also say, like, I'll back to what you're saying, Sean, that keeps them pretty motivated. And like when they get to that step, they're doing it the right way. Whereas like, a lot of times people will test like single leg hop to compare sides and stuff like that. Like that's so easy to cheat out of. Like you could get someone who gets just as far as the other or further, but like completely like lands on their toe or something like that. So it's like, I feel like that's really just a obscure measure to really use for return to sport. Whereas like you need to see how they move. You need to make sure they know how to get their torso in line. And like, if you're doing those things prior to getting to that stuff, then like they know how to do it at least. Whereas you would probably want to just see them move as opposed to like, oh, you can single leg hop on both sides to the same distance. Like, that's great. Now you're going to go play in a soccer game. Like, no, that's not how it works. And I would just say also from like personal experience from tearing my ACL, like you don't feel normal until like a year. Like people will be like, oh, I want to get back. I was like that. I was like, I want to get back. But like, I really didn't feel like myself until like a year.
Yeah. And even in the NFL, they say a player doesn't feel totally back to normal until the following season. So they have to play a full season of, 16 games until they start feeling completely normal. And you can do all the objective testing you want, but if an athlete doesn't feel normal, then how safe is it for them to return to sport? So that's something big to keep in mind for like high school athletes who want to play in college. We really can't rush these as much as we want to. We can't rush people returning to their full activity, especially if they don't. And they won't necessarily tell you that they don't feel normal, but we can kind of guess that if NFL athletes don't feel normal for an entire season after they go back, then a high school athlete probably won't either.
Yeah, and that's where the onus is going to be on us because, from a surgeon standpoint, they're doing this thing. They maybe see someone at a post-op meeting for not too long. Probably the PA is going to see them for longer. All they have is this window via objective measures. So they have these things that they care about that they've determined that, are showing how well the progress is going. And the onus is on us to look at those more dynamic measures, talk about things that aren't just, the physical things, like frame that early with the patient who's coming off the ACL or going into the ACL, that like we can have a relationship with the person that they probably won't have with their surgeon. When someone goes into a post-op protocol, or a post-op visit, they're so nervous. All they want to hear is that they did well and they can go on to the next stage. So they're not going to go into the surgeon and probably be like, yeah, I'm feeling kind of anxious about this. Like, I'm really not sure what to expect. Like, that's our role. So it's on us to be good about those less purely objective measures, like a triple jump or single leg hop test, like Bianca said, and like be able to see these more functional dynamic movements and determine what that means for them and be very open with them about it.
So I guess just to summarize that last part, it's a really multifactorial kind of decision returning to sport. There's a ton of stuff that goes into play. And I think a huge part of that is subjectively how the athlete or how the client physically and feels, because that's such a big role. I think with the other aspect of returning to sport that the studies are showing now is not only are we worried about the surgical side, but then the other knee can also be at a higher risk for re-tear. So it's like we're not just thinking about your one knee, we're thinking about the entire athlete as a whole, and there's a lot to consider there. So I think the more conservative we are in getting people back to sport, probably the better in the long run. Is there anything else you guys want to add in regards to the recovery process?
I just want to bring up like the neuromuscular side behind the recovery. So there's some pretty interesting studies looking at actually like brain functional MRIs in people who have had ACL reconstructions and people who haven't. And they found that the area that's associated with the leg, the affected leg, is actually different in both people. So that brings back up the point that we can't just say, okay, what's physically going on here? How's your strength? But we have to say, okay, how well are you stabilizing your leg when you're doing things like cutting and running and jumping? Because there's going to be a huge difference in function between before you tear your ACL and after. So what I think, either consciously or subconsciously, what our goals are is to normalize how we're absorbing force and producing it versus worrying about the physical implications of what the ligament is doing. I mean, we know that the ligament limits that forward translation of the tibia, but in my opinion, it's much more valuable to think of it as like a neuromuscular feedback mechanism where the ligament is telling our brain what our leg is doing. So if we can't normalize the neuromuscular aspect of it, and we only worry about the physical aspect, oh, let's prevent this force from occurring again, then I think we're missing a key piece of rehab, which I think we all do really well, is integrating kind of neuromuscular timing and sensory integration and putting it all together at the end versus just worrying about the physical. Okay, let's make sure your tibia doesn't go forward on your femur again. And I think that's a really important part of rehab that a lot more people are getting now.
Yeah, I totally agree with you. Like the whole thing of like, well, don't let your knee go in, but it's like, okay, well, they don't know how to do that. You have to make sure they're feeling the right muscles, make sure they're landing properly by engaging those muscles, not just being like, hey, notice how your knee's going in. Like, don't let that happen. Like, that's not really going to transfer over when they're playing in a game or something like that.
So I wanted to ask you guys, given that we're in this age of information being so readily available and so many people kind of referring to themselves as rehab or ACL experts or specialists, whatever that is, when they're not actually licensed physical therapists, this is a really tough time for patients, just because it's so hard to decipher what's good information, what's useful information, and what is potentially harmful. So how do we exactly navigate those waters with our patients and really set them up for success when they're physically not working with us? How do you guys handle that?
I think it's just making sure that you have a conversation with your client and knowing exactly who they're going to see outside of you. I mean, if they're not going to be coming to your clinic or seeing you, get the information. Where are you going? Who are you seeing? I want to have a conversation with them. I want to know, what they're about, what their credentials are. I want to know how they're going to progress you. I want to sure as heck make sure I can put my 2 cents in. And specifically for if it's a high school kid, I'm going to have a good conversation with the parents. I mean, you're going to build a huge relationship with their parents who are going to be able to facilitate what they're doing probably better than the kid is. I mean, they're just going to do whatever they want. But if you have a good relationship with the mom or dad or whoever, and be like, listen, this is the game plan, this is the approach. If you're going to be going to see this person, I want to make sure I talk with them and touch base. But this is what they need to do, and this is what you have to watch out for and be aware of.
I think to go off of that, also just kind of communicating with the surgeon can be a huge help on this situation too, of just being like, hey, like make sure you're still going to PT, especially in our younger athletes. Whereas like with the older population, I'm not as concerned because a lot of them are probably just going back to like normal day running every day and stuff like that. So like if they're going to go see someone else or they're going to go to bar class, like, and that's what they like doing, like I'm not really interfering with that. Whereas if I have a youth, like an athlete, I'm kind of like, hey, like make sure you talk to a surgeon and see what he wants you to do PT wise, like on your next follow-up.
Yeah, I'd say if you're the patient, just starting with obviously trying your best to develop the relationship with someone you trust in terms of a surgeon. And then off of that, it's going to just be kind of a domino effect of the people you see after that. So getting in with a physical therapist you trust, like if you're with someone, and this happens to absolutely everyone, they could be the best therapist in the world, they could be the friendliest patient in the world. Sometimes you just like don't develop a relationship with that person. If you feel like you're in that situation, like this is the rest of your life, this is definitely the next year of your life. So find someone that you trust. And if you have that sort of relationship, be completely transparent with them about what your goals are, who you want to see. And then on the PT side of it, it's finding out who that person is, the experience that they have, because there are definitely strength coaches who have a lot of experience with working with this population, and they know all the stuff that we know about getting back to this or getting back to sport. But there's also people that might be trying to take advantage of, people coming off an injury and just trying to market themselves. And the therapist is going to be the person who's better able to filter out some of that information than the patient will be.
Yeah, for me, the biggest thing is that the communication. I mean, if you are working with someone and they go see the best ACL rehab strength and conditioning professional in the world, how much does that matter if they don't talk to you because you saw them for the first 3 months or so? And, this other person should be able to say, hey, this is what I found. What did you find? And to me, it's a big red flag when this other person either A, doesn't actively seek out, the PT who's been working with this athlete for the first 3 months, or B, which I've experienced, doesn't answer your emails, which in my opinion is, it doesn't matter how good you are. If you can't communicate with the other members of this person's team, then it's going to be a huge detriment to the end goal of getting this person back to sport. I mean, communication is key in all of these situations.
Shameless plug. That's why, our setup works great, because we've got people literally that we eat lunch with that are continuing to see our patients that turn into their clients. And a lot of times it's going on at the same time where we're treating these people and working on maybe some like the more range of motion goals, some lower impact stuff. And then, if it gets time to it, they're either, our trainers are seeing them for either one-on-ones, or they're getting into group classes and getting back to stuff. So that communication is vital. So just, if you are a patient, being very transparent with your therapist about it. And then once that happens, it's on the therapist to be reaching out and trying to figure out who they're seeing. Because like I said, a lot of us, I think that physical therapy in some aspects doesn't do a great job of getting us in the mindset of return to sport and the aspects of sport. So a lot of the things that we appreciate of that end of the spectrum come from the strength and conditioning world, either of us being strength coaches in our past or, getting credentialed in it. So that world has a lot to offer to these patients and clients. But we just got to make sure it's somebody that has experience with, dealing with some of the medical issues that can come up.
So for patients who are either immediate post-surgery or they're anticipating surgery, we get the question a lot of how long should I go to PT, and what exactly does that rehab process look like from a timeline perspective? If you guys were to give your elevator speech to one of those people, what exactly would that sound like?
I think in terms of an elevator pitch, it's important to, set up a framework of what's going to happen, what to expect as you're going into it, because people get more frustrated when they have expectations and they're not met than if you set, this is probably what it's going to look like right away. So right off the bat, it's probably going to be a year from post-surgery until you're feeling really comfortable going back into sport. The first 6 weeks are going to be tough. There's going to be some pain. You're going to be in a brace. You're not going to be moving around as well as you are going into the surgery probably. After that, we're slowly going to reintroduce you to some sport-like activities, moving in some different directions, starting slower, speeding that up a little bit, getting back to running, somewhere between, a range of 3 to 5, 6 months. It really depends on the person, and then slowly ticking back up into sport. But right around that year mark is where we're looking for getting back into it.
So I guess to wrap up, ACL tear and rehab, it's a pretty lengthy process. But I think if you kind of break it up and hit the benchmarks of each particular stage and work with a good licensed professional, you're going to be kind of well on your way to getting back to what you want to do. And hopefully, you won't have to come back to us. I don't know. That's all I got. What do you guys think?
Thanks, Cam.
Good work, Cam.
Thanks, Cam.
Thanks, Cam.
I called it an elevator speech. I mean, it's not an elevator pitch. That's not an elevator speech. Is not an expression.
It is now.
Cam, go ahead, say it again. I'll
Just
try
my own expression. There you go.
Cam, if we could count the times that people said expressions that were a little wrong in this, it'd be a lot.
That's very true.
Oh my God.
That makes me feel better, Tyler. Appreciate that.